Great. Thank you so much, and thank you everybody for joining us today. My name is Megan Carolyn. I'm the Director of Policy Research here at the Institute for Child Success, and my job today is to set us up for a fabulous conversation with two presenters and then get out of their way while they share some really fantastic programming and knowledge with you all. We're grateful to all of you for joining us today. The webinar recording will be available afterwards. Just some quick housekeeping notes, though I think at this point we all live on so many Zooms, we're used to this by now. Because we're in webinar mode, attendees are muted, but there's still plenty of ways to get in touch. We have both the chat and the Q&A options activated. What I would encourage you to do is for Q&A, send in any questions that you want us to keep in mind for the panelists. We'll either sort of moderate those as we go or save them for a Q&A session at the end. We'll be taking more audience questions at the end as well, so do feel free to keep those coming. And then use the chat box if there's anything that we need to be aware of. Someone's audio is cutting out, or you're having some type of issue seeing the screen, etc. We'll monitor that while we go. I'm going to talk a little bit about, sort of what brings us here today, but first I want to just give a quick introduction to our wonderful panelists who have joined us today, and they'll tell you more about themselves in a little bit. We have Shelley Schoenfeld, who is the Chief Marketing and Client Services Officer of GOMO Health, and Callee Boulware, who's the Regional Executive Director of Reach Out and Read for South Carolina, North Carolina, Virginia, and DC. We are really interested to bring these two fantastic speakers together today and to talk about their programs, because it's a great conversation and sort of similarities and differences and what we can learn about program models moving forward. Lisa, could you go to the next slide? We've sort of been referring to the models that we're going to talk about today as quote unquote light touch interventions. There's no hard and fast definition of light touch versus heavy-handed as sort of one of those you know it when you see it. But light touch programs are generally less intensive and less costly than the heavy-handed programs. Things, for example, like a preschool program focusing on early childhood, which requires time in the classroom, specific student-teacher ratios, those types of things are going to be considered more intensive. It's a significant investment of startup resources, it's a significant investment of time and energy for the staff, for the families, et cetera. And generally those heavier interventions are often in person. What we like about light touch interventions as an organization, ICS, we think that there's a lot of potential here, and this is why we're interested in both GOMO and Reach Out and Read for customization to meet the specific needs of families. Some things that we really want to put on your radar at the beginning of this conversation, why we think that these two models make a great conversation together, is that they really do meet families where they are. Some models can be in person, some can be virtual. Right now our whole world is virtual, right? But it allows for scaling up or scaling down based on what a family needs. These programs can also have multiple impacts beyond stated goals. What we mean by that, and I'm not going to talk too much about this because I know Shelley will talk a little bit about the science behind their intervention, is a lot of these programs really focus on nudges and helping parents build confidence for some of the skills that they need. And so it's not just about a one point in time measurement of 6 months later the family was doing X or Y, but it's about building that belief and confidence to keep those good habits going well into the future. Many of these programs are used alongside more intensive approaches, and nobody on this call would say, we don't need any preschool, let's just have light touch interventions. We recognize that different families need different things at different times, and they can be used powerfully in combination. And to that end, I just want to also put on your radar this quote on the right from a great piece hosted by the Brookings Institution. There's no silver bullet. We're not here today to say that either model or both models together are the silver bullet to fix every problem facing American families right now, but to just show another opportunity for engaging partners who maybe haven't been part of a conversation before, think about different ways of engaging families and making sure that we're meeting them where they are. So with that being said, I am going to put myself on mute and hand things over to Shelley with GOMO Health to get us started.
Thank you. So thank you, Megan, for the intro, and I'm excited to team up with Callie here today. I'm going to be speaking about early care, which is a program that is based on our behavioral and cognitive science of engagement, and we'll talk more about that as Megan referenced throughout the course of the presentation. Before we get started, a little bit about me. I am with GOMO Health, and we provide patient engagement and provider engagement programs in a mobile environment, also as Megan referenced. My areas of expertise and experience are in patient and provider education and engagement, and really focusing on what makes people tick. How do we get somebody to take an action, any action that we want them to, whether it's an adult, a child, a clinician, a colleague, anybody. People operate in different ways. They have different triggers. And today we'll talk about those specific attributes that make each person take an action. And that process is based on a proprietary science that my company's founder has been developing for the last 20 years, specifically the last 10 in the healthcare space. It's called Behavioral RX, and we're going to talk more about that today. We apply behavioral RX to our programs, and we touch about 8 million patient lives a day through various programs and touching on many different therapeutic areas. Today we'll focus on early childhood development in our programs in that space. And a little fun fact for you, just because we're all talking about child development and these important people in our lives. I'm the mom of 3 avid readers, haven't had a book out of their hands since day one, and maybe even in belly I would read to them, but they're absolutely voracious readers. And in line with our presentation today, that's about where their commonality ends. They are all unique. They all have specific interests, and they all have their own individual motivators that make them tick. So we'll talk a little bit about that as well. Before we get started, I just had to share this quote. It's one of my favorites from James Heckman, with whom you might be familiar, but it's specifically focusing on the fact, as we all know, that those years from birth until about 5 are crucial to make an impact on children's minds, their interests, their development, and especially in underserved and underprivileged populations and environments, it's just crucial to make that connection early on. And that's really a foundational principle that we're going to talk about today that really guides a lot of what we do in our space. So to tell you a little bit about our behavioral science, behavioral RX, we believe that people are not just made up of their condition or their clinical environment. Certainly that's a factor, and that's the medical side of things. That's the biology and the chemistry and the physiology of people that we're trying to reach. But people also have their social factors and their cognitive factors, their socioeconomic factors, and they have emotions and behaviors and the way they process things in their own brains. And those are things that we need to consider when we're trying to motivate a person or treat a person in whatever that means, whatever treatment means, or nurture them in whatever way. We need to consider all of those factors. So in behavioral RX, our science, we have various technologies that we employ to engage and motivate people to take action. This is a sampling of them. We're going to talk about the ones that are specifically appropriate to this early childhood audience and to the parents and caregivers that we're touching through our early care programs. One of the important things that really guides our methods is that we believe, and our science is based upon the fact that, yes, we're looking for outcomes, as Megan said, and as Lisa said, we're talking about improving outcomes for parents and children today, and that's super important. But to achieve those outcomes, it's just as important to think about how are we going to engage our audience in a way that gets us to that final outcome. And that's what we're going to move into very shortly. So there's a lot of things that we consider when we're creating programs and thinking about pathways for connection with parents and caregivers and children. And a lot of those are human factors. You know, the data is important. We all want to know about the numbers and the results and the outcomes. But what's the input? What are the human factors that get us to that end game? So we need to think about what are the emotional factors that affect somebody, the physical, the spiritual. What could they be dealing with behaviorally? What are, maybe they're dealing with anxiety, depression, especially in today's environment. My goodness, the rates of depression, anxiety, stress, and distress that our world are experiencing is incredible. And they've escalated greatly since COVID-19 has entered our every aspect of our lives. Some people have medication management issues that they need to deal with, which could, of course, directly tie to those behavioral issues. They have comorbidities, physical conditions that they need to deal with, mental health issues that they need to deal with. We need to think about that too. And then, of course, there are the social determinants. People are concerned about income, transportation, housing, and food. So when we're trying to talk to somebody about their clinical condition and about their physical development and about child's development, we need to think, we're talking to parents, we're talking to caregivers. Their number one priority might be where they're laying their head down tonight and what food they're putting on the table for the family. And those needs must be met before they think about the greater, what might be considered ancillary things, because they're worried about basic human needs. So all of those things are really, really important to consider when connecting with our audience here. And this covers a lot of those social determinants and child and family development factors. And I just wanted to share before we go into the details of the program, when we're talking about outcomes, these are some of our outcomes. This is feedback that we've gotten from moms and caregivers and people in programs like the ones that we're going to talk about today. Everything from, you know, you're helping me in this time of Corona madness. I need reminders about caring for my kids. I need reminders about caring for myself. I feel like I'm a good parent, but I need help along the way. I need coaching, I need nurturing, and this program is really helping me with that. So this is always very motivating for us to get this sort of feedback. And we get this all through surveying of our populations that I'll tell you about as well, and about from the people who are participating in our program. So before we get started, back to Science 101, one of the things that we know is that in order to have a lasting impact on somebody and to really be sticky and to have them learn something and apply it and really retain it, your best probability to have that happen is to stimulate as many senses as possible. So when people fully experience something rather than just reading it or experiencing it in a passive way, when they're actively experiencing something, they're much more likely to retain it and apply it and stick with it. So I want to tell you a little story about stickiness. This is Bella. This is the youngest of the three voracious readers. And Bella recently started, again, you have to educate a child according to their way, right? So every child has a unique way. Bella last year started in a Montessori school. And for those on the line or in this webinar who are familiar with the Montessori experience, it's all about experiential learning. It's not a frontal teaching method. It's not children sitting at desks, which works too. Our other two children are in that environment, but it's about the experience, and that's where they really believe child growth happens. So Bella started in a Montessori school last year, and at 8 years old, I walked into the kitchen one day and she was cutting, knife, serrated, an apple for a snack all on her own in the kitchen. So this mom was very nervous when I saw that. And Bella must have seen the look of shock on my face. And she said, "Mommy, don't worry. I do this in school. It's part of my job," because in her environment, they're learning to be functioning members of a community and of their classroom. Their classroom is their community. And each of them has jobs to function and contribute to that community that they're building. So she said, "Don't worry, Mommy, this is one of my jobs in school. I prepare a snack for my classmates." This, of course, before our COVID environment. And she said, "I know how to do it. And my teachers taught me how to do it, and I can be safe. And if you want, you can watch me so that you understand and that you have that confidence that I can do it. And at the end, we can have this snack together. So I thought to myself, take a step back, chill out, Mom. Yes, she's using a knife. It wasn't like a super sharp one, but she was using a knife sharp enough to cut the apple. She did it with ease. She did it carefully. She cleaned up afterwards. We had the snack together. That's really what it's about. It's about the experience. She's able to influence her environment. She's able to reassure me, the parent, I can do this, Mom. She's been nurtured to do that. She's built her confidence to do that. And she's really in an environment where she's building a partnership where she can be successful. So when we talk about changes in behavior, employing all of those different attributes is where we'll really see success and retention. So that's Bella. Don't tell the other two that I featured Bella today because they might be upset. So moving on to our program where I'll really show you the nuts and bolts of early care and what we do. Early care is a mobile-based program. So everything we do is in a mobile environment. And you can think of the early care program as a virtual concierge for parents and caregivers. So they become a part of this program. The program is designed for children from 0 to 8, as we know that that's a crucial time frame. We actually go up to age 8. And we focus on delivering content and resources and support to parents and caregivers in all different formats, which we'll get into the type of content that we deliver. And everything is age appropriate. So one mom might get information about her 2-year-old, her 4-year-old, and her 6-year-old. Another mom might be the mother of a 3-month-old. And the content that they receive is only appropriate to the age of their child. Again, personalizing that experience so mom understands this is for me, this is about me, this is meaningful for me. We base our program on 5 guiding principles. And they're all outlined here. We really believe that you need to engage somebody within their own environment. You can't be an interruption. You need to be a complement to their daily life. And that's what our programs do. We time our messages based on their preferences and things of that nature. We build trust and credibility so that they view our program as a reliable source, just like Bella built her trust and credibility with the apple cutting. And we take the data and feedback that we get from our program participants to create care models, predictive care models, so that we can anticipate the needs and that we know that based on the evidence that we're gathering, these programs are structured in such a way that we're really meeting the needs of the caregivers and parents that we're speaking to. The program focuses on various areas that a parent or caregiver would need help with in order to do their best job with their child. So it's everything from language and literacy and learning and educational development, and it couples with the basic, as I talked about earlier, those basic health needs of the child, which might be everything from safe to sleep or a period of purple crying to how to properly change a diaper or latching on for nursing. It could be anything like that, but it's a combination of all of these different areas. So let's talk a little bit about the componentry of the program. How does it happen? We have program marketing, and we partner with various organizations to deliver this program to the moms, parents, caregivers in their service areas. So there's various marketing materials that we create in conjunction with our partners. It could be a poster, it could be a brochure. We do digital and social advertising. We know that moms, as the female head of household decision makers, they're online, they're in social environments, and we can really target those advertisements to those moms. So that's a lot of how the promotion happens, to create that awareness. And once the moms become aware of the program, super easy enrollment. So they just text a keyword. In this case, I'll have a demo for you at the end where you can actually experience this yourself, but they text a keyword to a short code. So this is just like a text experience you might have with a friend making plans for dinner. Your short code is where your phone number is, and your keyword is where your message body copy is. So you text that keyword to the short code. And once you do, you get a text response with a short message that has a link to a survey. And the survey enables us to learn more about the program participant and enables us to gather that information so that we can customize the content that we're sending to them. Once they complete that survey and we get that baseline information from them, including the children's age and birth date, so that we can provide them with appropriate age-specific content, we start delivering all the content that I mentioned earlier. And that content can be in the form of brief text messages, which are limited, of course, by character count. And they can also contain, the text messages, a URL that would take mom or caregiver to deeper content. So content that's not limited by the character count of a text message, but to a mobile web page that would give them additional information on that particular topic. That mobile web page can be text, it can be copy, it can be media, it can be a video. We have links to various content providers where we have partnerships and relationships, so we can link to their content as well. And all of those web pages are housed within what we call a companion. So it's a learning management system, which is accessed by the mom through that message that she gets with the URL. So she gets the message, she clicks on the URL, she goes to the deeper content, and it's all in this house of content and information. Mom can also access that house via URL. So it's just like a website. She goes to the URL directly, and she can access any of the content. It has a table of contents and an index of the content that's available to her. Now, super cool feature of this is, as I mentioned, we survey moms and caregivers throughout their program participation to find out that what we're delivering to them is still the priority of information of what they're looking for. Based on what they tell us, our system, which has a sophisticated business rule engine that powers it, our system can sort the content in this companion based on mom's priority. So if mom expressed in the survey that she's having trouble with getting the baby to go to sleep, she has sleep-related content that's at the very top of the list when she accesses the companion. If she's looking for new material or reading to share with the child, if she's looking for speech development tricks, that'll sort to the top of the list. So it's a smart system that enables us to deliver the content that's most important to mom. And again, it can be video, it can be interactive, it can be multimedia. And once we have all this feedback from mom and we see her participation in the program, we're able to report back to our program partners, here's what the moms are looking for, here's what they're reading, here's what they're clicking on, here's what's of most interest. So we can report back on how many people enrolled in the program through the text-in, how many opted out, which is generally pretty low. We have about a 96% retention on all of our programs. How they engaged, if they clicked on a URL, how long they viewed a video, if they asked any questions within the companion, which they can do, and any of the survey feedback that they offered up. We can offer survey summary reports, graphs, and reporting based on what mom shared with us. So it's all collected in real time and available to our program partners through an admin portal. So that's our early care program that's been designed to nurture parents and caregivers and children up to age 8. And if you want to experience that, you can do that after our presentation here today. And you can text early care to 52046, and that'll give you a sampling of this early care program. It'll be not an actual experience. You'll get message after message in what we call kind of a gunshot mode. You'll get them one right after the other, where a normal program is, of course, spread over time, over the age of the child, but it'll give you an idea of the type of content and resources that can be shared with mom throughout the course of our program. So I thank you for your time. I thank you for listening. And I believe we're taking questions at the end. And Callie, I think you're up next.
Shelley, that was so awesome. I appreciated learning all of that and hearing more about all of that. And Lisa is going to be in charge of my slides, so you will have to hear me saying next slide throughout the presentation. So thank you for your patience with that. But it's great to be here with you all. My name is Callee Boulware, and I have had the privilege of supporting the Reach Out and Read intervention now for almost 20 years. I started my work in South Carolina, and we grew to become the Carolinas about 10 years ago. And just in the last year or so, started working with our providers and programs in Virginia and DC. I've been able to really see the Reach Out and Read intervention grow in scope and in quality and in sophistication over the last 20 years. And the world looks a lot different now than it did 20 years ago when I first started this work. I mean, heck, that was before the iPhone, right? But there are some really lovely constants that we see and that I get to see in the work every day. Children and families still need to snuggle up together with a story, with some time to talk and some time to be together. Today, just as much as they ever have, maybe more. And at Reach Out and Read, we're committed to making these moments a reality for children and families every day so we can build strong brains and build strong relationships across our shared communities. And then I'll be ready to jump on in there, Lisa, whenever you're ready. There we go. Thank you. So these, you can just go ahead and populate all of this, Lisa, at once if you want to, but basically what we're looking at here together as an intervention is to figure out ways to help families make those everyday sort of routine oriented moments, special moments. We know repetition is something that's very important in children's lives, and I would argue in parents' lives as well. Repetition is a very important thing. It builds a sense of normalcy and security for families. It creates some sort of predictive routines and things that make children feel really comfortable. And it helps families create sort of modes that allow for the kind of interactions that we want them to be having to be just a part of their day, not something that they have to think about or work on necessarily building into any moment. So as Shelley mentioned, I loved her story of her daughter and of that experiential learning and the quote around experiencing things through multiple senses. And what it made me think about are these everyday moments when we're really trying to create a multi-sensory experience for children. We're trying to create a time like we probably all love the most with our own children or other children in our lives, but just a time where we're not distracted, we're sitting together on the couch or whatever time of day that might work, and we're snuggled up and we're spending just some undistracted time together, talking, reading a story, listening to your child talk about their day, pointing out things that you love in a book, sharing stories about yourself and your family. Just the opportunity to be together. And we think that it's very, very special. And that's really at the heart of what Reach Out and Read is here to do. Next slide. The other thing that's really unique about the Reach Out and Read intervention is that it truly is a two-generational, or I'll say multi-generational intervention. So the intervention is designed to work through the primary care medical home. So we're meeting families in a place where they're already going. Children already have to go to the doctor a lot of times between birth and 5 years old. So at all of those touch points, we are working together with our trained medical providers to support and skill build and encourage and empower parents and caregivers, grandparents, older siblings, everyone who is sort of around that young child to create moments every day that allow for healthy brain and healthy relationship development. By encouraging this and encouraging families to make those everyday moments matter, we believe that this spreads not only between the family, but out into the community and creates a different way that we all can learn to be together, which we think is very important. Next slide. So what is the Reach Out and Read intervention? I like pictures better than words. So I'd like to use this image to kind of show what the Reach Out and Read intervention is. But really, we call it kind of resilience building, teaching families how to be together, teaching families how to bond. We know that time spent together with a book and the shared language that happens in that kind of an interaction builds relationships, builds brains, and builds sort of the social and emotional health of that child and that family. We know that we have somewhere between 14 and 15 opportunities to do that with children and those who care for them between birth and 5 years old. That is a lot of repetition. That is a lot of repeated reinforcement and support of parents and caregivers as to the things that they can do and that they are ready to do and equipped to do every single day that can be transformational for their children's lives. So let's go on to the next slide where I do have some words to talk a little bit more about that picture that I showed before. So these primary care providers who are our partners are trained in the Reach Out and Read intervention through a continuing medical education training process, and then continually trained as they implement Reach Out and Read over time. They integrate the Reach Out and Read program into the entire way that they practice well care. This is one of the reasons that we always say Reach Out and Read really is something that is a lot like clinic transformation. It's not something that's just a program that you can add on at the end of the visit, or something that you just kind of, some doctors do, some don't. When we partner with a medical practice, everybody in that practice has to become trained in Reach Out and Read, and it really changes the way that they care for families. It becomes a new approach to the way that they do well care with children and families. So there is the lovely intervention and touch point that happens between the clinician and the family behind the doors of the exam room, and the provider is really meeting the family exactly where they are, talking about their child, talking about their dreams and their goals for their child, and the ways that they can create these daily interactions that will help to achieve those things, providing the support that that parent needs to know how to do that and how to be that person in their child's life. And the thing that I love maybe the most about the entire intervention is the repeated reiteration of our doctors and primary care providers tell families, which is, you are what your child needs the most, exactly what you are. There's so many things in this world that I think tell parents that they're not enough in a certain way, or they have a deficit in this way, or that this is something they need to improve at. But really, our doctors can tell the families over and over, you and your attention and your time is what your child needs more than anything in this world. And I'm here to help you do that and help you figure out ways to make that a reality in your day. And then families leave the provider's office with a prescription to read, and we have literacy-rich clinical environments that accompany all of this. Now, before we go on, I think we talk a lot in this model about what's valuable for parents and children. I also want to make sure I mention what's valuable for providers. Part of the reason that Reach Out and Read has always been a provider-designed and provider-led intervention is because this becomes a really critical tool in the provider's tool belt. This becomes something that allows our medical providers to assess development and sort of do developmental surveillance in a new way. So we have providers who walk in the room, they walk in the room with a book in their hand and they hand it to a 6-month-old baby. What's that baby going to do? She's going to chew on it, right? She's going to put it right in her mouth. And the doctor has the opportunity to say, oh, look at her, she's so smart, that's perfect. This is exactly what she's supposed to be doing. As providers go through the Reach Out and Read intervention over time, they might hand the child the book upside down. They want to see, can the child turn the pages at an appropriate age? If I ask the 5-year-old to find a letter from their name and tell me what letter they see here. So this also becomes a really critical tool for the provider in assessing child development, but also in helping to support parent-child engagement and interaction. They get a really critical lens into how does that child and that parent interact together around this book? What does this tell me about their strengths? How can I help to build on that family's strengths? And how can I help to skill build in places where I see opportunities in that parent as well? So it's a really genius model. It's embedded in a pre-existing structure of the well visit, and it's something that's highly valued both by families and by providers, which is why it has been sort of able to excel and scale so significantly over the life of the intervention. Next slide. And of course, we all know, as Shelley mentioned too, that the first 5 or 8 years of a child's life, and really 80% of the brain is developed in the first 36 months of life. So we really have to capitalize on those very earliest touch points to create the reality that we want for children as they age. So Reach Out and Read works because of all of these things, because that primary care home touch point is a critical reoccurring touch point for over 90% of kids. There is no other system in the early childhood space that reaches anywhere close to that number of children. So Reach Out and Read, unlike so many interventions, truly is a population-based approach, which, to Megan's comment earlier, allows us to do some beautiful scaffolding. Reach Out and Read can be present for really all families, and then we can scaffold other interventions on top of that as families need additional supports. And critical to mention, Reach Out and Read is not a book distribution program. There's a book, and it's an amazing and very important part of what's being catalyzed in those Reach Out and Read conversations. But the magic of Reach Out and Read is really that provider-family relationship and engagement and training and support and education. And then the book is the prescription that we're sending home with families, so they have the tool in their hand to implement what the doctor is helping them to understand is an important part of their everyday lives. Next slide. We have a wonderful provider who is on our national board of directors who always says that Reach Out and Read is a secret parent support program. And I like the way he says that, because secret in so much as parents often don't even think that they are being taught something or educated in some way, but all of us, can understand the feeling of wanting to do what's absolutely best for our children. So in our parents and caregivers, we have an opportunity to really help families feel strong and empowered and encouraged in their skill sets so that they feel like they're able to help their child progress and develop in the ways that they want them to do so. These consistent, positive, responsive interactions from a caring adult are one of the most important things we know in helping to mitigate the realities of stressors that live in families' lives. Number one most important thing is a constant and responsive and caring adult. So let's work together at every single checkup to help families be ready to play that role in their child's life. Next slide. And then the other fantastic thing about Reach Out and Read is, of course, that we do live in the medical space, which allows us to be a part of a lot of research that's happening. A lot of the early research in the Reach Out and Read world in the first 20 or so years of our intervention really looks at a lot of the language outcomes for children, receptive and expressive language skills, more readiness for school upon school entry, changes in parent behavior. Parents are much more likely to listen to their doctors and sort of implement that prescription to read and that advice and that guidance. And also quality clinical environments, increased relationships with families and those primary care locations. And those are all phenomenal outcomes that we work very hard to make sure we can sort of expect for our families through a very important eye on fidelity to that model and how we are measuring and evaluating the quality implementation of this model. Now, I think the really exciting thing, looking at the evidence bucket here, is how Reach Out and Read is moving. We've been hearing for years anecdotal feedback from our providers about all kinds of other impacts and outcomes that they see in families when Reach Out and Read is done well in their practice. Some of those include impacts on well visit compliance. How is Reach Out and Read's presence in a practice an important factor that helps to increase compliance and continuity with well care, which is important for so very many things, like we know. How does Reach Out and Read impact, again, deeper quality clinical relationships between providers and families, which allow for conversations that get into deeper levels of trust? As Shelley pointed out earlier, so many of the other social determinants and challenges that families are facing, if that level of trust is higher, parents are going to be more likely to engage with their providers about areas where they need help and support, and they can get that help quicker. How is Reach Out and Read even a potential tool to help mitigate maternal depression? How are we able to help mothers figure out early ways to bond and have positive interactions with their babies when that can be very challenging? And how does Reach Out and Read ultimately impact the healthy interactions and relationship development between families? There's a growing field that we're all, of course, a part of in the work that we do contextually, but it's, academically called early relational health or many other things. But I think we very simply can call it, how are we all working together to help children and families build healthy relationships together? How are we helping families create the moments and the interactions and the skills that allow for that development of healthy relationships, which is at the core of anything we want for children. School readiness is up here if we're thinking about a big old iceberg, right? It's at the very tip top, and we use it a lot as a proxy for understanding child development. But really underneath all of that, the big piece of that iceberg under the surface is all of the relationships that those children have had the opportunity to form and how that has helped to prepare them for that academic learning. Next slide. Oh, the best way to see Reach Out and Read is just to show you. So I'm going to show you one of my very favorite videos, and then we'll talk a little bit about it in a minute.
Hello, how are you guys? Oh, you're okay. Can you say okay? I think you're learning a lot. Those are good for you. Yeah. You might remember that we like to give books out at all of our well visits because we think it's important for kids to love to read. Yeah, what do you see? Do you like to read? Yes. Yeah. Well, we just love that the kids get the books early. We hope that you like to read with her. I don't know if there are any times of day that you might spend with her looking at a book or on the weekends.
It's mainly on the weekends that I read to her mother.
And she's also with grandma sometimes too.
Yeah, and she reads her.
Great. So that, you know, when she was littler, she would put everything in her mouth. You might remember we were talking about that. Now that she's older, she probably won't do it that often. She'll do it a little bit less. But every once in a while, she's still exploring using her mouth and all of her new teeth.
Yes.
And you know, she's still going to test things. You might see that she, you know, is doing so much better using her fingers to open the book. And she'll also be asking you to read the book. And where before she might just look at it, if she likes the book that you have, or she's interested in something in it, like a cat or an animal that she sees, she might be getting your attention by hitting the book. But she's just really doing great with loving that book.
Yes. It's difficult where I don't read to the girl as much as the mother. American. I know she does use that as the calming tool just before bed. Two good books, one of the girls pick out a book, no more. Sometimes I stand in the bed for the story too. So we all get in the same bed, we listen to the story, we put it to bed. But it's definitely a calming tool.
Well, we love that because they're learning from you how wonderful it is to be together, to be together as a family, or even just you and Nyla, and reading the books together is a really nice activity. Different from everything else that you might do to be with them. I really want to read the book. Should I read the book? You're tricky. Go ahead.
Nana. Hello, little girl. What are you doing? That's the mouse. Oh, I see. Are you going to pick that red, ripe strawberry? The big hungry bear can smell a red, ripe strawberry.
No, actually, she does like this book. She's exploring it more. She's doing what I would expect a 1-year-old to do. If she was 2 or 3, she might be a little bit more interested in the next step of the story, the next part of what you're telling her. You're going to notice that she's going to start pointing to things and that you can point to things. The kids are really, really in the phase now where they're learning a lot of words. This is the age. She's been listening to you all along, but now she's starting to say a few words. So the more you can point to things and say the words and encourage her to do that, the better.
Thank you so much for making that work, Lisa. While we're getting back to the slides, I just want to point out a couple of things. I've probably seen that video 100 times, and it is one of my very favorites of all of the video banks we have of families experiencing Reach Out and Read for a couple of reasons. Number one, there's so much that we learn about that child and about their family and about the way that they are cared for through that conversation with that provider. We learn about the family's daily routines. We learn about the different people that are a part of caring for Nyla. We learn a lot about her relationship with her daddy by looking at the way she looks at him when his voice starts. There's just a lot of magic in that moment and in understanding what we can learn from that moment and the teachable interactions that have happened in that very short time together with Nyla in that book. So Reach Out and Read does this at every single touch point that families have between birth and 5 years old. So you can imagine this kind of a depth of interaction happening over and over and over. Similar to what Shelley talked about as well, there's a lot of opportunities for layering. So you know, perhaps around one example might be either sleeping routines or the integration of solid foods or the development of oral health and connection with dentistry for children at different ages. A lot of times reading becomes a part of the development of those routines too. So it's not done in a silo of do all the other things and read. You know, it's all really integrated into the ways that we teach families to develop bedtime routines, limit screen time, spend time playing outside, all of those things. It really is integrated into how we share books and stories together. Now, like everybody else, there have been significant impacts on the way that our families are experiencing things now through this time. But the really important thing to think about from the Reach Out and Read perspective as it relates to the pandemic and how it impacts families is that though most other interruptions, most other touch points and systems have been interrupted or many remain very interrupted, children are still being seen in their primary care settings. Children are still supposed to be present and in person for those well visits, especially our youngest children. So we still have a very unique and even more unique opportunity for our doctors to be face-to-face and talk to parents and children and give them extra and added kinds of support during this time, which is particularly challenging for parents. A couple of interesting things we've been thinking a lot about through the pandemic. Number one, everyone has seen the absolute necessity of normalcy and routines, and snuggled up with a book, reading bedtime stories or dinner time stories or whatever time stories have worked for your family. That creates a sense of normalcy and resilience and security for children and families through challenging times like this. Very critical. Children and parents alike need that sense of normalcy and routine right now so desperately. We've also been supporting our providers in adaptations they have been having to make very early on with telehealth, making sure we still have reach out and read rich, meaningful interactions with families through telehealth platforms, or absolutely whatever well care looks like for doctors and families. We want to make sure that we are there and are helping to train and support those providers to make it a part of whatever way they are caring for families. And of course, now as we're looking at the impacts of the pandemic on immunization rates and well visit compliance, the numbers have been staggeringly low. So how are we using some of that relationship and that nudging that Shelley mentioned and some of those positive feelings about the reach out and read intervention as a part of clinical care to nudge families back into the well visits to make sure that they are compliant with their immunizations and very other critical screens and checks that are happening in those well visit spaces. I like to say we don't want to just get families through COVID. We want to help families thrive through this COVID, right? So how are we going to really help families thrive through? And it's in the development of these routines that help them get through their days. Next slide, please. One other really critical component of Reach Out and Read that we have been working on has been the backing up to birth. So a couple of years ago, Reach Out and Read in the Carolinas is really the first place in the country to systematically back up Reach Out and Read to begin at the very first visit after birth. We used to begin at the 6-month visit. And now we know we can't waste any touch point in those critical early months of brain development in a child's life. So now we're backing up all of our programs to begin at the very first visit after birth, which has increased our dosage by 40%, which is significant. And especially through this time right now, it allows us additional face-to-face, in-person touch points with families in those very critical early months. So this has been a really exciting change in general, but a really important change through the pandemic. Next slide. I know I'm slow here. I'm getting to my time here, so I'm going to kind of run through this. But one of the most important things we also do as an intervention, outside of providing consistent light touch support for families, is to also provide ongoing training and support for our provider community, who have a lot of things coming at them all the time, a lot of demands on the way that they practice medicine. So what we're trying to do, similar to the alignment Shelley was mentioning in her conversation, is really help providers gain a larger understanding of the ways that their work with Reach Out and Read helps so much in their developing families' lives. So we have a robust online learning community for our provider network to take part in CME certified courses on a variety of topics. And we are constantly in conversations with our providers to understand what do you need to learn more about, and creating bite-sized learning opportunities to continue to help to support the things that they need to do Reach Out and Read in a very high quality way. And the next slide really focuses on, we don't have to obviously read all of this, but I just wanted to touch on the critical nature of fidelity and high quality intervention of an evidence-based model. Reach Out and Read works, it works very well, and we talk a lot about the evidence of the intervention. And that really is only meaningful when we implement with fidelity and when we make sure that programs are doing the Reach Out and Read intervention as the research supports, that medical providers have the training and the support they need, that we have the right books in the hands for the children at the right times, that we have quality sort of literacy-rich environments, and that our program manager team is able to provide the intense one-on-one technical assistance with our programs to help them maintain that high quality intervention over time. And we'll end, next slide, we'll end right there. I just want to really end on the magic of Reach Out and Read coming from a few key places. Number one, the consistency of touch point, those 15 times in a family's early years, that trusted voice of the medical provider, and that skill building and engagement of parents is very, very powerful in a time in their lives when raising children is a little bit on the scary side, right? So everyone's feeling a little insecure, and to help to be able to build their confidence and help them understand what they can do for their children is profound and meaningful. And Reach Out and Read is really built on this foundation of helping families develop those early relationships. So thank you for your time today, and I look forward to any questions.
So thank you both for your fantastic presentations, a little bit of a crash course on your program. We do have a few questions that have come in through the Q&A, so just a reminder through the chat, you can keep sending questions. If we run out of time, we'll get you some answers by email. I want to start with one of my questions first, and then we'll go into the user questions. You know, it's interesting, Shelley and Callie, that you both use different terminology, but your programs are talking about so much of the same, right? Meeting families where they are, customizing from, what you learn from them, these small, bite-sized touch points. Callie, I appreciate the conversation about COVID impacts, because I can't be the only person who laughed to myself when you said that families thrive on normalcy and predictability. I don't know the last time we've had some of that. But really agree that having these built-in checkpoints through both programs is so important, to know that there's somebody on the other side who's still checking in when we've been cut off from so many of our networks. I want to talk a little bit about inequalities and access, and sort of any barriers to program engagement that you all have seen. I think anytime that we talk about programming, we have to think about who is it hardest to get involved. What are linguistic barriers that your programs have had to counteract? Is there, Shelley, is there a technology phobia that some parents are having with the programming? Or Callie, is it difficult sometimes to get folks into those appointments on the right schedule because of work and transportation and pandemic? Just making sure, we talk a lot when we think about school readiness. A lot of parents go into their child's pre-K or K year with their own negative experiences of the educational system, and that colors their experiences. Whereas you all sort of have this different engagement network. They don't have that baggage that they're bringing in, but there could still be some very real barriers to equal access. So I'd just love to sort of hear about some of the challenges you've experienced with the programs and how you've handled them.
So as far as access, that's an excellent question. As we all know, and it's not an uncommon question. We get this question a lot when we're speaking to different providers of our programs. And I always bring it back to, as I mentioned earlier, I have little kids who are they want a device, they want access, they're all about mobile, right? Kids are just all about the technology. And when we get the question, oh, but do adults use it, and what about the access? I think about my mom, who's on her phone constantly, and God bless her, she's 80 years old yesterday, happy birthday. So everybody's using mobile technology. Everybody's engaged in that, and we believe that in order to be successful you have to go to the person. You can't expect the person to come to you. When you have a resource that's going to help somebody manage a clinical situation or a socioeconomic situation, they're not really going online and searching out, my kid's been vomiting all night, what should I do? Or I feel sick, what should I do? But if you're providing them with a resource that's delivered to them, they're more likely to engage with it. So for example, our program, no app to download, free to the end user. It's device agnostic, it's web-based, super duper easy. And we see equal engagement across all ages. So when we're delivering a program for moms, whatever age that mom could be, and many of our programs are in underserved populations, as I mentioned, Medicaid populations, we could be talking to a teenage mom. We could be who nobody knows that she's pregnant. She hasn't told anybody. She feels she can be more transparent because she's behind a phone and she doesn't have to be looking at a provider in the face, answering questions, or looking at a parent or somebody like that she needs to answer to. So she feels comfortable and transparent with that. And we see that they're fully engaged no matter what the age, as long as we remove the barriers, we remove the obstacles, and we go to them and we make it personal to them. So we look at the determinants. And for a 16-year-old who nobody knows she's pregnant, she has no circle of support, she has zero confidence level in managing this situation, we're going to talk to her differently. The tone of the messaging can be customized for her. For a mom who's 35 and has 3 other kids and she's pregnant with her 4th, we're going to talk to her differently because her mindset is different. So we try to remove those barriers to increase engagement and activation.
That's great. I love that personalized touch that you can do with folks. That's really cool. I think that from the Reach Out and Read perspective, you know, we prioritize when we're growing and sort of identifying clinics, we're prioritizing those practices that might serve families that are disproportionately at risk for some of the factors we've talked about. So we're sort of working on that in the way that we pick clinics where we want to operate and train those providers. We're also working on making sure that those clinical environments have all the tools that they need for different language needs, different cultural needs, all the things that they might experience, nuanced needs of their population. I think one interesting thing that we've seen through the pandemic, and I've had many of our funders, other people on the other folks in Zoom conversations who have expressed significant fears of bringing their own children in for their well visits and have themselves not been compliant with the well care. And so what we can see is that there are certain kinds of fears that are just across the board. And so one of the most important things I think that Reach Out and Read can do is really help to, again, use that trusted voice of the doctor and the trusted voice of, it's my job as your provider to care for you and your family and your children and their health. And I would not give you information that was not good, that you could not rely on. These are the ways my clinic is safe for you. These are the ways that I'm making sure that you and your children are safe in this space, and really use that trust and that relationship to help families understand why compliance with those well visits is so critical and so important for them and their children. So again, it all goes back to the development of those relationships you have with families. And once you have that relationship, you can figure out how to meet the needs.
I think those are great points. Thank you both so much. Lisa, I want to check our end time for today is 2 o'clock, correct? Okay, great. So folks, we are at the end of our time, but what I'm going to do is pop into the chat box here contact information for both Shelley and Callee, as well as my own information. If you have a question that you want to go to both of them, we can do that and circulate back with the answers. The slides will be posted on our website. A recording will be posted on our website. I also put into the chat box, just for reference, the code that Shelley gave everybody if you wanted to take a look at the sample of the early care program, so you can go ahead and text to that. So thank you all for your engagement today. Again, follow up by email with any additional questions for our presenters. And Shelley, Callee, I just want to thank you both for making time for another Zoom call on everyone's very busy virtual schedule. I think this was a great conversation. I mean, I'm familiar with both of your programs and I learned new things today. So just really grateful for the engagement and for the discussion. And thanks everybody for making time for us in our afternoon. Take care.